in pediatric heart surgery, it is a little bit unique. I think if we're going to go out into family practice or even a pediatric practice or something of that nature, I think those roles may be a little more even.
Dr. Thomas Maxey and Abby Young, physician assistant extraordinaire. I'm excited to chat with both of you for a different type of e-shadowing session. How are you folks doing?
Hey, Ryan, good to see you. Doing great.
Hi, thanks for having us on here. I appreciate it.
Thank you. And I have to give credit to you, Dr. Maxey, for your suggestion of hey, I'm a pediatric surgeon. I could come on and talk about pediatric surgery, but I also have lots of PAs who I work with, and it'd be a very interesting discussion to talk about that dynamic that a physician, a PA, the other kind of ancillary staff and other healthcare providers, how we all take care of patients together and what that looks like and how we can potentially train and educate a future physicians coming up through training and some future PAs who may be in here listening to really hopefully help continue to strengthen that working relationship.
Yeah, absolutely. I just kind of stumbled across this and for, total transparency, when I went through my training through general surgery and cardiac training, there were a couple PAs that were around or, some form of advanced care practitioners, but certainly not to the level of, what there is today. And that is the future of healthcare. I think, to think that you're going to get into practice and not have to work with non-physicians, you're in for a big surprise. So, it's a unique group of people that are very well trained, highly intelligent, and, they're my colleagues. We work parallel together. And I think that's something that's really come about in the last probably 10 or 15 years, I would say. When I was in general surgery training, 15 or 20 years ago, there were no PAs in the hospital that I worked in. So it's new, but it's, it's refreshing, and I think it's helpful.
Yeah. For you, Abby, how did you end up in the pediatric cardiac surgery world as a PA?
So briefly, right after PA school, so my first year out of PA school, I did a fellowship for PAs at Texas Children's Hospital, and I did it in pediatric surgery. So like med students, PAs rotate through different rotations throughout their schooling, and our fellowship is very similar. I spent time in pediatric neurosurgery, pediatric ENT, and pediatric heart surgery. And during my rotation, I was able to go on a heart transplant, and we took off out of Texas and flew to another state. And it was a really rewarding experience for me. After fellowship, I wanted to come back home to Charlotte. I actually emailed Dr. Maxey, didn't even know him at the time. I had another colleague that I was working with in Texas, gave me his email address. And at the time, there wasn't a pediatric position available. And I actually took on a pediatric orthopedic job as a PA, which was a great experience. I was able to develop patient care skills, working one-on-one with the surgeon, being in the operating room, enhancing my surgical skills. And then this job came about, and I knew that was my calling. It was the right time in my life to change positions and come into this role, and it's been fantastic since.
That's awesome. So, Dr. Maxey, from your point of view, you're the surgeon. Is a PA a surgeon as well? Where is that role for a PA in the operating room? And as you go on, I gave you a warning that I have 2 kids upstairs and they're screaming, so I'm going to go while you talk.
Yeah, no problem. I'll try to answer that. Thanks, Ryan. Take care of your kids. Yeah, I mean, the operative environment, clearly there is a surgeon, whether it's a cardiac surgeon or a neurosurgeon or orthopedic surgeon, but most operations today need an assistant. And, that role of an assistant is far beyond just, holding strings or holding hook or putting a sucker here and putting a sucker there. Abby, for example, truly understands the operations that we're doing, and it's a dance. when we started together, despite your skill set, I mean, remember I talked about a dance. We got to learn how to dance together. And, so your role in the operating room is crucial. I'm no better or no worse than I was a year ago, and probably not going to be any better or worse next year. But I think as our working relationship improves, the operations get smoother.
Right. I think the biggest thing that PAs need to look for in a supervising physician or a surgeon to work for is that relationship in the operating room, to be able to kind of roll off of each other and really understand what he needs or she needs next. And I think that's where the PA can be very handy in the operating room. We really need to feed off of one another and understand what the next move is before maybe even the surgeon knows his next move or her next move. The PA needs to go ahead and show the surgeon what he or she needs to be doing next, really show them where maybe there is a good suture bite to take, and really present the whatever surgery we're doing, present it well to them. And honestly, it comes from a lot of technical training from the surgeon. And again, as a PA, you need to look for a supervising physician or a surgeon who's willing to teach. I came in with surgical experience in the orthopedic world, but that's very different than doing heart surgery on a 2.5 kilogram baby. So you really need to look for a surgeon who's going to teach you what they want out of every procedure.
And I think being a PA, specifically in the operating room, is a very unique skill set. In other words, Abby is a better assistant than I am, if you can follow what I'm saying there. Her view from the other side of the table is different, and she has the skill to see what I see, which is a different angle and those sorts of things. And that's an acquired skill set that, I'm gonna be honest with you, some people just don't have. It's it's an innate ability to kind of see things in reverse. She needs, in her mind, to be able to see what I'm seeing and what I'm having difficulty with, show it to me better without getting in my way, and let's make this operation go smoothly. And, as we spoke before on your previous podcast, it's pediatric heart surgery. There's a timer on everything that we do. So, efficiency and movement is key.
How do you, and this is maybe more for you, Dr. Maxey, in the business world, life in general, especially entrepreneurs, business people, and I'll speak for myself, I had a really hard time, and I still struggle with it sometimes, delegating things and trusting that the person I'm delegating to is going to do it up to my standards and as perfect as I want it and as whatever as I want it. How have you learned, or maybe it's just innate and you're a very trusting person, how have you learned to work with PAs in the operating room and outside of the operating room to take care of your post-op patients?
Yeah, I think the trusting component has to be there. But that being said, I'm ultimately responsible for everything with the patient, with the child. So, that I hold myself to a very high standard, and I hold Abby to a very high standard. And when we first started working together, I remember, I'm anxious to hear her comments on this, but I remember saying something along the lines of, I'm going to ride you pretty hard for 6 months. When you don't do something right, I don't know a polite way to say that that's wrong. Or you need to do that better or quicker or, more efficiently.
Yeah.
I think that for me, that works well. It's a level of clarity. I expect excellence from myself, and I expect it from everybody around me. And if I don't deliver it myself, believe me, I'll be the first to say it. And if Abby's not delivering it, I have to say it, because I don't mean to sound cliche. There's a child's life at stake during this. So, I think that relationship was very clear. I thought it worked out pretty well, the first 6 months. I'd like to hear Abby's thoughts of that. But, I trust her. I really do. I trust our other PAs as well. But that came with a training period of, this is what we expect in pediatric heart surgery, and it has to be delivered.
Mm-hmm. Interesting. Abby, what are your thoughts on how that trust was built over time, or what you did as a PA to help build that trust, or other situations where the physician wasn't as trusting and was more hesitant, where you were able to build trust?
Right. Let's see. I think with Dr. Max, it was a very easy relationship in the beginning to be able to go to him to ask questions. Hey, I'm really not sure about this. Hey, will you just come look at this baby with me? I have a couple of thoughts in my head, but I'm just not totally sure. And I think as a PA, you really have to be able to find that physician that's going to go up 8 flights of stairs with you to look at a kid and see how they're doing, and really be able to say, hey, my PA is just, there's something going on and I really need to trust her that I need to go see the patient and we need to move forward with surgery or whatever it may be. But again, Dr. Maxey gave me some reins to kind of go out there and make some feelers and let me do some things by myself, and then let me make decisions by myself, which was really encouraging for me as a PA. I need that as a PA as well. I don't want to be going to ask questions every 2 seconds about every patient. The physician also needs to give me a little bit of boundaries to go out there and see the patients on my own, but know that this might be out of my scope of practice. I'm going to go run it by him, or I'm always going to update him. And I think over those 6 months, or even from the 3 years that we've worked together, he knows that I'm going to come and update him on every patient. We're going to talk about it. And if there are any changes that need to be happening, we can make those together.
Yeah. Interesting. So talk about, and maybe a surgical PA isn't the best place to ask this question, but I know it's a question that pre-meds and medical students are getting more and more. And with the recent announcement that the physician assistants kind of society now wants to change their name to physician associate, how, as a physician, and then I'd love to hear your thoughts, Abby, how do we not see you as competition?
How do the physicians not see the PAs as competition?
Yeah. And both of you can answer.
Okay. Would you like to go first?
Yeah, I mean, regardless of the name, I have heard of that, but I haven't really thought about it until you just said it there. I think our world, in pediatric heart surgery is a little bit unique. I think if we're going to go out into family practice or even a pediatric practice or something of that nature, I think those roles may be a little more even. Mm-hmm. But I can only answer that from a personal standpoint, and I don't mean to sound obnoxious. I mean, I don't view that as competition. We're partners. I have my role. She has her role. They're very well defined, and that's why we work well together. But your point is valid. I'm curious to see what Abby thinks about that the difference in family practice versus pediatric heart surgery.
Yeah, I'm in a couple of groups of PAs in this area in North Carolina, and their talk about can PAs go out and be the manager of their own practice and not needing a supervising physician. Like Dr. Maxey said, in our role, in our setting, that is never going to happen. Definitely need a physician and a PA or a nurse practitioner. I don't think as PAs we see it as a competition ever. We very much respect, and I am talking for the physician assistant community, we very much respect the physicians and all the training that they've had to go through, which is a lot more than we have. We get a lot of on-the-job training and really, really rely on our physicians to teach us on the job. We learn what they're learning in medical school in 2 years or less. So we really rely on them. And so I don't think we see it ever as a competition. I think we see it very much more of a respectful situation where they have put in hours and hours of training. So I don't see it like that at all in any situation.
Yeah.
I don't think it should be.
Yeah, I don't think it should be either. But I know there are lots of concerns out there about it. So thanks for answering that one for me. I know it's a hot button one. When it comes to talking with patients and the PA is seeing the patient post-op, Abby, from your point of view, how do you handle potentially patients who are like, well, I want to talk to the doctor?
Yes. Yes, I've heard that multiple times in my orthopedic career, and now I want to see what the doctor is saying. And a lot of times I just say, hey, I'm the doctor's right-hand person. I've heard that multiple times, that you're my right-hand woman. And really, I'm an extension, as you know, I'm the right hand. I am an extension of Dr. Maxey and all of our surgeons' practice. And I have been able to follow him around so much. I know his lingo. I know what he wants the parents to hear. And I'm really saying, you know, what he would be saying at the same time. So I explain that to the family, that I'm have followed him, and this is kind of, I'm an extension of his practice. And I try to relay that to the parents. But honestly, at the end of the day, these parents are having their child, who is a couple of days old, is having heart surgery, and the surgeon, you know, is the one responsible for it. And so at the end of the day, I try and explain everything that Dr. Maxey would be talking about, the anatomy, the surgery, any post-operative expectations, and go over everything to really ease their mind. And then at the end of the day, I'll always have Dr. Maxey or any of our surgeons, hey, I'll have them give you a call. We will meet first thing in the morning. We always have the surgeon meet them at some point.
Yeah. I'd be interested to know for both of you, how long did it take, and maybe you're not even there yet, for it to be comfortable having the confidence to talk to these patients about their child's heart defect and the surgery they're going through and the anatomy, and knowing, like, I know this inside and out. I'm comfortable talking to you about it. And I wonder if there's a difference for, like, Dr. Maxey. It's like, well, it wasn't until I was a 10th year attending, and or you, Abby, you're like, 6 months in.
I'm definitely not there yet. I mean, I was like speaking scoliosis lingo and you know, radius, breaking, you know, bones lingo for quite a while. So it definitely, I'm still there, still learning. We were just having a little learning session before we got on. But you know, the first 6 months I was following him around everywhere, just listening and picking up everything that he was saying. Maybe about a year or two, probably 2 years in, I started feeling comfortable talking to patients by myself, patients' families, by myself, to really explain the defect and the surgery. It takes a lot of hours of just watching the surgery. A lot of times we'll have another surgeon scrub in, and I will stand there and watch, which is really interesting too, because, you know, say another surgeon is scrubbing in to assist Dr. Maxey. I'm not watching Dr. Maxey. I'm watching the assistant, the other surgeon. I want to see what he's doing in the operating room, or she's doing in the operating room. Which way is she pulling the string to show him the right next move that he needs to take? You know, you don't want to pull a string one way and cover up everything he's saying. So I'm really watching the other assistant. And so that's another part that I took on over, you know, 6 months to a year, is just really watching every surgery as much as I can, over and over and over again. We do a vast array of surgeries, about 150, but there's some ones we do regularly. So I really try and get those down pat by watching Dr. Maxey or the assistant surgeon. I think that really helped a lot.
Oh, that warms my heart. I love to hear her say that. That's fantastic. Now, I think the role of the PA talking with families, I find it helpful. In clinic, if we have, you know, kind of several patients there together, you know, it's nice if Abby can kind of go in and at least kind of lay the groundwork with the family. This is how surgery is going to work. You're going to meet the anesthesiologist. You need to come in for a pre-op appointment on this day. You typically go to the ICU for this many days. You're going to have a breathing tube and drainage tubes. And then at this day, you typically go to the regular hospital floor, and, you know, kind of lay the groundwork of just kind of what to expect from surgery in general. And then I can kind of swoop in at the end and kind of talk about the surgery. Unfortunately, I have to talk about the risk. Regardless of how many times Abby or her colleagues have talked to families, and they're all excellent. They probably give a better speech than I do. But I have to go through the risk. I need those words to come out of my mouth to the family's ears. Even if they've said it 10 times, they're going to hear it from me one more time. These are the risks of this particular operation. And I kind of think that my mandatory, vocabulary that I need to deliver at that time. But
yeah,
again, I think Abby and her colleagues set me up great, so I can kind of come in and hit the real meat of it without explaining, this day we're going to change the baby's diaper to this. And, I really don't even know all that stuff. So,
yeah. Talking about the fully informed consent piece of talking about risks, right? The risks of the surgery, whatever procedure. You like saying that. Is that a legal thing, or is that just you as a human being, as a person, or like, I'm the one doing this, so I need to tell you what may go wrong?
Yeah, I don't think it's a legal thing, but me as a person, if I'm going to be holding your child's heart in my hand, you need to hear the risk from me who's doing that. Because if one of those risks occurs, even a non-mortality, but the kid has heart block and needs a pacemaker or something after the heart surgery.
Interesting.
I need to come, when I have to go tell the family that, I feel comforted knowing that I spoke to them about that before the operation. That's not something out of left field that I hope Abby told them that, so
1,000%.
Yeah. Those words have to come out of my mouth. And like Abby said, we do so many operations, and, there's some common complications that can occur within any of those, but some of them are very specific for the operation. And, I don't know, I guess to answer your question, I don't think there's a legal component to it. But I think from a humanistic standpoint, it's the right thing to do.
Yeah. I don't think there's, go ahead, Abby.
I'll just piggyback on that a little bit. Being able to watch Dr. Maxey go over the risk with families, it can bring tears to your eyes sometimes. It's very hard to hear. I can't even imagine if it was my child. It's hard to hear as the PA standing there listening to him. But I think that anybody listening to this, if you take one thing away from tonight, when you are speaking with families, everyone is on an equal playing field. And it doesn't matter where you come from out of life. Dr. Maxey stands up, he shakes your hand and looks you straight in the eye and talks about the risks. And I think that really gets the parents' attention and really almost gives us a respect. And because they know that we are respecting them and their child, he stands up, he shakes their hand and says that he's going to take great care of their child, but is very serious about the risk and looks them straight in the eye. And he usually says, I'm going to look you straight in the eye and I'm going to tell you these risks. And he doesn't want it for his child. Definitely doesn't want surgery for these children. But these kids need this surgery and we have to go through with it. And they're very hard to hear, these risks. But again, he stands up, shakes their hand, is very serious about this, but also comforting at the same time, and lets them know that we're really good. We do this every day. We do heart surgery every day, and we're going to take good care of them. But I do think it's a very serious thing that any doctor listening or soon to be doctor listening needs to take into consideration when they're speaking to families.
Yeah. Abby, for you, a lot of students as they're pre-med or pre-PA, they're deciding, do I want to go to medical school? Do I want to go to PA school? You obviously went the PA school route. You are in and around surgeons all day long, seeing the operating room. Is there ever a time where you're like, I wish I went to medical school?
No, never, never. I mean, I think my story is a little bit different. I have heard a lot of times, well, I didn't get to medical school, so I'm just going to try PA school. And that is not the case. I think Dr. Maxey, we talked about this in the very beginning when I was first intrigued by this position. People who want to go to medical school and people who want to go to PA school are two different mindsets. We have the same goal of taking care of a person, but I think what we want to achieve is different. And I never wanted to go to medical school, never even thought about it. When I was 15 years old, I was playing soccer and got hurt, saw a PA that night, changed my life drastically. That same PA is a mentor to me, was invited to my wedding this past fall. Huge person in my life. We talk probably monthly still. And the reason I went to PA school was he was so comforting and calming to me and saying, we're going to get through this. I was like, I need to be you. I want to be you for somebody else. This is amazing. And so I really never wanted to go to medical school. Never even actually crossed my mind. I knew at 15 I was going to PA school, and that's what I was going to do for my life.
Nice.
So.
Nice. For those of you watching, if you want to come on and ask a question, we'll take a couple questions. We're going to end tonight a little bit early. Respect these busy people's time. So if you want to come on and ask a question, we'll take a couple questions. What haven't I asked that you think students need to be aware of about the PA physician/surgeon dynamic?
I think it's, and this is just, I'm sure you've talked about it on your other PA podcasts and stuff. The good part about being a PA is you're malleable. You can, do heart surgery for 5 years or 10 years and then go be a dermatology PA. Yeah. So the downside of that is there's turnover. I love working with Abby. She is fantastic. Do I think she's going to work with me for the next 35 years of her life till the day that she retires? I mean, I would like that, but realistically, that's probably not going to happen. So, I think because you have the ability to, as a PA, to kind of move around. If she were to get a job offer in neurosurgery in Kansas City that was attractive, she may take that. Versus you and I, Ryan, we're kind of, you're kind of stuck into what stuck is kind of a bad word, but I couldn't go be an orthopedic surgeon. I'm a pediatric heart surgeon, and that's, I either do that or nothing. Yeah. So I think the downside of it from the physician standpoint is there's turnover. Yeah. The upside of it from a PA standpoint is, you have options. Yeah.
Like I said, I did pediatric orthopedics before this, and can go and do something else tomorrow. I'm not going to. I have the best PA job, I say, in North Carolina. Yeah. So I think another big thing from being a PA and being a doctor is that we have to establish a good rapport with each other. We have to be able to get along. We enjoy hanging out. There's 2 other surgeons and 2 other PAs on our team, and we have lunch every day together because we really like to be around each other. We know each other's families. And Dr. Maxey asked how the weekend was, wants to know, what's going on in my life and vice versa, which I think is really important.
So I have a very, very important question. How compatible do music tastes have to be to be together in the operating room?
Oh boy.
He's like rocking out to I don't even know, 80s classic stuff, and I don't know anything about music.
So you're calling him old.
Who sung this song back in 1983? I have zero idea. Like they now ask me because they think it's funny because I don't know. Yeah. But I'm learning a little
Justin
bit.
Timberlake was not in Led Zeppelin. Let's just put it out.
That's incredible. All right, one more serious question, then we'll go to Daniel. For you, Dr. Maxey, going back to the malleable part of a PA career potential, how has that potentially changed your thinking on how we train physicians? And is the graduate medical education system something that could be changed so that we can be malleable as well?
Yeah, that's got me a little curveball there. Let's see. Let me try to answer that from a cardiovascular standpoint. That's kind of my world that I know. Ryan, when you and I went through med school, there was a medicine track that led to cardiology, and then there's cardiology has electrophysiologists and cath doctors and heart failure doctors and transplant doctors. And then there's surgeons, there's cardiac surgeons and thoracic surgeons and vascular surgeons and pediatric heart surgeons. I think those siloed things are not the future. Heart surgery has changed. Heart surgery has changed over the last 10 years to where the boundary between cardiologists and heart surgeons is a little more blurred. We now have teams of heart teams, structural heart. There's cardiologists and heart surgeons that talk about Mrs. Smith's mitral valve disease and what's the best way to treat this? Can we treat it in the cath lab? Can we treat it in the operating room? Can we do hybrid procedures that are, a little bit of both? So I think, probably not going to answer your question exactly, but the siloed approaches of you are a GI doctor, you are a GI surgeon, you are a heart doctor, you are a heart surgeon. I think those boundaries are a little more blurred, and I think we're going to be training cardiovascular specialists, 20 years from now. The role of the cardiologist that I knew 25 years ago is different. It's different today. So I think more of a generalized training into a new world of specialty services, I think, is probably the future. And I'm sure there's other examples, but from a cardiovascular standpoint, I really see that occurring. And one further example, heart surgery training today, it didn't happen in my fellowship, but it's there today. The heart surgery fellows have to go to the cath lab and learn wire skills like the cath doc, like the cardiologists do. So there's a little bit of blurring of the lines there of those two specialties.
Yeah. Abby, from your point of view, from the PA world, I've heard rumblings that the PA world potentially is shifting more towards our graduate medical education system, where PA residencies are being talked about. What's going on with that, if you know anything about that?
Yeah, when the PA profession first started, it was really for PAs to be a family practice, a rural family practice provider. A small town has one doctor and then we need some help. And so that's really what it started as a profession. And now, a PA can specialize in anything, but our training is so broad. Every 10 years, we have to take a broad test. I have to go take a test on adult hyperthyroidism, so I have to do all these things. But we're becoming more specialized, where I do think fellowships are going to become more of the norm. Even when I graduated 6 years ago, there was very few. There was one pediatric surgery one in Texas. There are definitely more coming about. We have one here in Charlotte that encompasses all aspects of medicine and surgery. I think as time goes on, PAs are going to be more specialized. We're going to be more needed in the operating room with different fields. So yeah, I see it changing. Yeah.
Awesome. All right, Daniel, come on and ask a question.
Hey, Daniel.
Oh, we can't hear you, Daniel. Oh, no. Can't hear you. Keep trying. We'll come back to you. Tatiana.
Hi, can you guys hear me?
Hey, Tatiana.
Hi.
Yep.
Okay. I have a question. I'm glad that I'm going first a little bit, because I don't want to end on like a note like this. But when you guys were talking about telling the families like the risk factors, have you guys ever given like bad news to a patient, and like how did they take that, and how did you feel giving that information? I'm very curious.
No, that's a great question, Tatiana. As a pediatric heart surgeon, that answer is yes. I have nothing to hide from you or anybody on this call. Pediatric heart surgery has advanced greatly over the last probably 3 decades. The mortality is very, very low, but it is not zero. Nationwide, all the surgeries we do, including at this hospital and all the others, there's a mortality that's probably about 2.5%. That's a real number. When you're doing 400 cases a year, 2.5% is a real number. Okay, so that turns out to be about 6 or 8 kids a year that don't survive. And I don't think there's PAs that would do that, but again, that's why I go over the risk with families, because that is my job to go talk to families when a baby's not going to survive. And it is the most uncomfortable part of my job that there is. I've been doing this for 20 years. It doesn't get any easier. And I think the day that it does get easier is the time for me to hang it up. I'm a human more than I am a doctor. And I think, the loss of a child, the loss of your patient, in our world, which is a child, I can't hide from that. It's terrible. To answer your question, it's terrible. I have to do it. I have to respect the families, to talk to them and be open and honest with them. But it is the most difficult conversation. I've cried in front of families. It's horrible. And my family knows it for the next week when we lose a child. And, fortunately that is very, very, very infrequent. But I'm going to be honest with you. If it were much more frequent than what it is, I'm not sure I could do it. That's how terrible, 99% of the time I have the best job in the world. I'm convinced of that. 1% of the time, I promise you, I've got the worst job in the world. And if it were much more than that, it'd be hard to do. Did that make any sense?
No, that did. Do you guys have any advice for students who are pre-med to keep that in mind as they're going on this journey? Is there any tips that could, I guess, help prepare them for that?
I think that what I just described right there is humanity. It's not written in a book. There's not an MCAT cheat sheet that you can do to do that. I guess someone taught me that, but it's not something that I've practiced. The humanity in you will come out. If you're a good human and care for people, that's why you're going into healthcare, be it PA school or med school. It's there. The price you're willing to pay to be able to do this, you're going into this for altruistic reasons, and I don't think that'll change in your life. So I can't give you any tips. Be you. Be a human. Care about the patients that you take care of. You're going to see all types of patients, by the way. Rich ones, poor ones, fat ones, tall ones, black ones, white ones, pink ones, green. It's all there. And, I can honestly say I don't even see any of that. They're a patient in front of me that have a child that probably live a very different life than I live. But I don't, I'm blinded to all of that. And that's a good thing. The human nature of that it's natural. And if it's not natural, don't get in the game. I think if you have to fake it and study and learn how to do this, I'd recommend another field for you. It's a great question.
Thanks, Tatiana.
Thank you. That was very insightful. Thank you.
I had Dr. Maxey on Specialty Stories. It's posted at the top of the chat, specialtystories.com/206. And we actually got into that quite a bit in terms of how do you bring that home and how do you deal with that kind of psychology. So that's awesome. Yeah, that humanistic aspect really hit home for me because when I did my internship training, I did it at a hospital where one of the floors was a prison. It was the Department of Corrections hospital, and we would get prisoners. I would have to put my badge in and go through the prison gates and then close that door and wait for the next one to open. And we're trained at that point, you don't ask why they're in prison. What did they do? Because you don't want that to affect your judgment of taking care of them as a patient. And you have to do your best to just take care of them as a patient, regardless of whatever crime they did to become a prisoner. So it's definitely something that's very important.
Yeah.
All right. With that said, I'm going to end here. Any final words of wisdom, Abby or Dr. Maxey?
No, I'm glad we were able to do this together. I think it's a snapshot of healthcare and what it's going to be, and particularly in our world, the relationship between the physician and the physician assistant it's vital to success. It provides joy in my life. It's rewarding. It's no different than a marriage. It takes work to pull it off, to make it happen. But I love it. I'm friends with Abby outside of the hospital. Her husband, her family, I know her parents. She's friends with my wife. It's it's a family that extends beyond the hospital. And regardless of what specialty or career you choose, if you enjoy your colleagues that much, you're lucky. Pursue it with a passion.
No. Abby, Dr. Maxey, thank you so much for your time. Just a little bit of admin housekeeping. Normally, you have to watch 45 minutes of these to get credit, but since we're cutting it short, 35 minutes will do. I wish everyone has a happy night. Again, thank you, Dr. Maxey and Abby, for coming on and sharing your journey together.
Yes, sir. Good seeing you. Y'all have a great holiday. Take care.
Have a great night. You too. Bye.
Bye-bye.